No, I think. Okay, President Joyce, we're all set.
All right, is there a motion to move to resume open session at 1:03 PM?
So moved, board member Finetto.
There a second?
Second, board member Chin.
President Joyce, yes. Board Vice President Kirkbride,
Yes.
Board Member Chin,
Yes.
Board Member Hall,
Yes.
Board Member Kroger,
Yes.
Board Member Patel,
Yes.
Board Member Pineda,
Yes.
Board Member Smith. Motion passes unanimously. We will begin with review and discussion of rulemaking hearing report mailing A with staff member Melvin.
All right, staff member Melvin, this is mailing A. This is our rulemaking hearing report for the hearing that was held on August 21st, 2025. This is related to our Division 110 fees for licensees and registrants. On July 9th, I noticed the hearing via Gov Delivery to 5,575 rulemaking adopted rules subscribers, and then I sent it out to 22,152 licensees and registrants. So everyone in the database received notice of this. People were invited to provide oral testimony during the hearing and encouraged to email their written comments. The hearing convened at 9:31 and it adjourned at 9:41. 6 people joined the public call to listen to the hearing. 1 participant signed up and 1 person provided oral testimony. And then the board received 16 written comments that they have been provided during the open comment period, which was 7/8 through 8/21. And the hearing was recorded and it's posted on our website. And I'm going to turn it back to you, President Joyce.
So this calls for like a brief board discussion to confirm the to affirm the comments. Board member Kirkbride.
No, I don't have any comments. I appreciate the engagement from the licensees.
Board member Smith,
Board member Smith has it at this time.
Board member Patel,
Board member Patel. We already done so many comments. More comments, and I appreciate licensing take time to write down the comment. I would say it's very not unfortunate that the way the whole process went down. And I guess we can do better next time.
board member Kroger,
Board member Kroger, I appreciate the interaction from the public and taking the time to submit the comments, and feel like it continues to be us to communicate clearly the whys and what we're doing kind of behind the scenes to make sure the public's well informed, but it is what it is, and appreciate the engagement.
board member Pineda,
Board member Finetto, I like to echo other board members and what they have said. Do appreciate everybody that came forward and did have something to say about it. You know, licensees have voices too. And unfortunately, this is where it is, and we are moving forward as it is, but everyone's concerns are felt and heard, and we appreciate you taking the time and reaching out, because what you do say does matter.
board member Chin,
Board member Chin, I have no further comments, but thank you to the folks who wrote in.
board member Hall,
Member Hall, I don't have any additional comments, but I did read all the testimony and appreciate all the comments, and hopefully, like board member Patel said, we can do better.
and as board president Joyce, most definitely appreciate the comments. I sent the sentiment there is clear, and I wish we could have done it differently, and I wish there was more transparency. The next time any kind of fee increase will happen, it will be done differently. Is there a motion to accept 2025 rulemaking hearing report?
Move, board member Kirkbride.
Is there a second?
Second, board member Chin.
Board President Joyce, yes. Board Vice President Kirkbride,
Yes.
Board Member Hall. Member Kroger,
Miss,
Yes.
Board Member Patel,
Yes.
Board Member Pineda.
Yeah.
Board Member Smith. Board Member Chin.
Board Member Chin, yes.
Motion unanimously passes. We will now review and consider permanent adoption of rules, starting with staff member Melvin Mailing B.
Thank you, Staff Member Melvin. This is to permanently adopt the licensing registrant fee increase that you just spoke about. I don't think we need to review the rule unless the board has any questions. I'm just going to turn it back to you, President Joyce, for board consideration adoption.
So it does require board discussion. Is that appropriate?
You could do a round robin if there's questions or.
Okay, well, in regards to licensee and registrant fees, we could just make a statement. Okay. Let's start with, Board Member Smith.
Member Smith has no comments at this time.
Okay, Board Member Patel.
Board Member Patel, don't have any comment. Did we increase the PDMP fee? Have it go 50 to 70, something like that, or it was always been 70? Just wonder. Tracy.
Staff Member Hennigan. That is not a fee increase in this package, in this set of rules that happened previously. It went from $25 a year to $35 a year. I could look up, I don't remember when that happened, but within the last several years.
That's fine, doesn't matter if you had to pay. Just curious.
Member Kroger.
Member Kroger, no comments. Thank you.
Board Member Pineda, any additional comments, clarification?
Member Pineda, no comment.
Board Member Chin
Board Member Chin, no comment?
and Board Member Hall.
All no comment.
And Board Member Joyce, so just one additional comment, because I do feel strongly about this, the way it was done. And there's strong feedback from the public. So, I did not agree with the 40% across the board broad brush fee increase for everyone. I thought it should have been stratified. But, next time it'll be done differently. It'll be a much deeper look into how we increase fees in the future. With that in mind, is there a motion to adopt proposed rules OAR 855-110-0005, OAR 855-110-0006, OAR 855-110-0007, and OAR 855-110-0010 to be effective upon filing.
So move Board Member Chin.
Is there a second?
Second, Board Member Kirkbride.
Board President Joyce, yes. Board Vice President Kirkbride.
Yes.
Board Member Chin.
Yes.
Board Member Hall.
Yes.
Board Member Kroger.
Yes.
Board Member Patel.
Yes.
Board Member Pineda.
Yes.
Board Member Smith. Motion passes unanimously. We will now receive a brief update from Executive Director Runyon regarding rules in development.
Executive Director Runyon, always struggle to get my workstation set up for the first time, so if I need to make any changes. Good afternoon. Pleasure to speak to you today about the rules in development, which is all of them since the last board meeting in August. So I'll just go down by stratification. So we'll start with current immediate priorities, and we'll move to high priorities next, and I'll wrap up talking about some of the work that we did for the respiratory vaccines since the August board meeting. Currently, in terms of immediate priorities related to legislation, of course, the Senate Bill 236, or related to the pharmacist prescribing of medications for opioid use disorder, or MOUDs, and pharmacy prescription lockers. I've still been working directly with pharmacists from OHSU's impact team. And have recruited several SMEs to help with the protocol. I'm still in the process of developing the base protocol for further consideration by SMEs and look to have this completed at some point next month. Of note, we had some fruitful on-site meetings with the DEA representative There are some next steps required with them in order for pharmacists to be able to obtain the DEA registrations. So we're happy with the progress we made there and are aware of next steps. And I want to emphasize a point that I made speaking at the OSPA annual convention a couple of weekends ago. The best protocol is rendered useless unless our pharmacists are compelled to use it. I've augmented the work that we're doing on this protocol with work that we're doing out in the community. And specifically, I've presented some bonus content or material. I feel like people always pay more attention when you phrase it as bonus content. So I presented some bonus content at that meeting, talking about opioid use disorder, MOUDs, and the manifestations and ramifications of stigma and bias in the medical community related to both of those, and ended that with a call to action. This was very well received, and to date is probably the topic I've received the most positive feedback on through outreach and education efforts over the last year plus. In terms of pharmacy prescription lockers, you'll hear staff member Efremoff talk about that at length starting later today. And as Senate Bill 236 also pertains to PPLs, we've made subsequent changes to the applications online, removing the PPL application from the list and adding a PPL designation in MLO to allow for the appropriate tracking of PPLs to ensure our compliance officers have the most up-to-date information while they're out in the field. And I'd like to recognize the hard work of staff member Efremoff that she put into this rule set in order to bring the revised version to you at this meeting. As you'll see later this afternoon, it was an extraordinary lift, and I hope that we can all find appreciation for that as we go through later today. Last on the legislative list, again, House Bill 3045, the HBSB bill, becomes active 1/1/2026, but as discussed last time, the State Board of Pharmacy may take certain preparatory actions before the operative date. Paraphrasing there, we've continued to have meetings with partner agencies to assess and unify best practices, monitoring and administrative requirements, etc., with the next one scheduled this coming week. And in terms of current high priorities, compounding, the remainder of which will be presented to you starting tomorrow. I would like to share that with some vacancy savings, one of my pipe dreams is to take some of those and do a direct appointment essentially for a temporary position for a SME to help craft the revised versions of those, since we don't have a pharmacist consultant currently. Next on the list of high priorities, the DSCSA. This will take precedence in the ensuing weeks over other high priority items and subsequent weekly rulemaking groups as staff juggle making incremental progress on this with continuing to make progress on the aforementioned legislative rules. And then lastly, I'll wrap up with pharmacists prescribing vaccines. As you're all aware, we succeeded in amending the respiratory vaccine protocols to be in alignment with the West Coast Health Alliance recommendations, thereby expanding and preserving future access for the Oregonians we all protect and serve. I'd like to take a few moments to say some things here. First, we heard you about wanting to take another look at the protocols. If I understand correctly, in terms of our intent, we're taking these back to the PFAC later this month. I think 10/22 is the meeting date for that. And then we'll subsequently bring them back for further review at the December meeting. Second, we also heard your request in terms of contemplating what I'm not entirely sure was brought up in public or executive session. So I'll just say that we did a preliminary assessment in line with a point that was raised in either of those sessions, and board counsel Hunt's determined that subsequent and more in-depth analyses are going to be required. So we hope to bring that back to the December meeting if possible, in coordination with bringing back the protocols themselves. And lastly, I can't sing the praises of my staff enough. Especially staff members Melvin and Efremoff for answering the call day in and day out to make this vaccine protocol revision happen. This was an extremely demanding 2-week period, and we accomplished this while still meeting the demands of the agency, hitting every single target, meeting every single deadline, preparing for every single external meeting and presentation with interested parties. And this required multiple meetings with the governor's team, various state agencies, associations, and teams, daily press inquiries, requiring agency staff to draft, review, approve, and or submit approved content. I was interviewed personally with a member or by the member of the Oregon Public Broadcasting team. And I could go on, I won't belabor the point, but just know that I couldn't do what I do without these two and the rest of my team, everyone that's here. And just look at the size of the packet that you've seen at this meeting as a testament alone, if you need convincing. I've consistently seen this entire team accomplish as much as teams 3 times their size, and I'm honored to work alongside them. To wrap up, following this board meeting, staff will consult previous board direction, the strategic plan, and the rules priority list to resume work as appropriate and as outlined above. President Joyce, I'll turn it back to you.
All right, very good. Thank you, Gary. We will now begin rules as policy discussion, mailing C regarding OTC birth control, oral hormonal contraceptive, proposed rules with Executive Director Runyon. Back to you, Gary.
Thank you. Give me just a moment to switch gears. Okay, Executive Director Runyon. So staff member Melvin has mailing C pulled up. So we'll go over the rule, and then we have a couple of auxiliary documents. I'll also read the letter of support from the Director of OHA. And then we have the standing order as well that we'll review. First, let me say I'm excited to speak to you today about this long-standing joint project between the Board of Pharmacy, the governor's team, OHA, and multiple other state agencies and associations with the goal of supporting equitable access to safe and effective contraception across Oregon. I'd also like to point out that we have a few members of OHA either present in person or on the call perhaps, that are prepared to speak today and answer questions if needed. So we'll cover some background information, again, the letter of support, rule revision, as well as the standing order. So part of the basis for this, for those of you who may not either be familiar or need a refresher, is the REA Act, or House Bill 3391. So what is the REA Act? House Bill 3391 is a bill that provides for expanded coverage for some Oregonians to access free reproductive health services, especially those who in the past may not have been eligible for coverage of these services. It also provides protections for the continuation of reproductive health services with no cost sharing, such as copays or payment towards deductibles, and prohibits discrimination in the provision of reproductive health services. Before we move on, I'll provide a little historical information or a timeline of some pertinent events for your consideration and context. So OHA met with the BOP to discuss potential access barriers for OTC hormonal contraception, specifically among Oregon Health Plan or OHP members. And of note, federal Medicaid law requires that for a prescription for OTC medication to be covered for a Medicaid member, the drug must be prescribed by a licensed practitioner that is enrolled in the state's Medicaid program. Although pharmacists can already prescribe OTC oral hormonal contraception in Oregon via statewide drug therapy management protocol, few pharmacists offer this service, and even fewer are enrolled as a provider in the state's Medicaid program, which is required in order for the prescription to be covered for OHP members. OHA identified a standing order as a viable way to meet this need, similar to what's been used for naloxone or short-acting opioid antagonists and immunizations. And we worked with OHA to identify potential barriers to development and implementation of such a standing order, which included the rules that we'll go over shortly, specifically Division 41 Operation of Pharmacies and prescriptions, general requirements in Section 1105. Board of Pharmacy then worked to create the draft language presented here today, which could circumvent this barrier approved, allowing pharmacists to utilize OHA's standing order protocol. And this protocol of note is limited to OTC oral contraception, furnished to OHP members, and would be signed by a licensed OHA physician enrolled as a state Medicaid provider, which I believe we have with us here today. And one of the last notes, people with private insurance can still get oral hormonal contraceptives OTC by either getting a prescription from a healthcare provider, getting a prescription from a pharmacist if available, or paying out of pocket and getting reimbursed by the insurance company. And also of note, pharmacists will retain the responsibility to exercise appropriate professional judgment in dispensing these OTC medications under the standing order protocol. And before we move on, I will share a little bit of my personal ideological journey through this. I've been involved in this, I think, for about a year now. We laid down the project for a little bit and then picked it back up recently. So this is my personal conjecture. Take it for what it's worth, which might be 2 cents, which might be nothing. I just, in being involved in this for such a long period of time, and having time to contemplate, the context and ramifications of the rule changes that we were going to bring to you, and what that would mean for people with OHP and people with private insurance, I did a lot of thinking, and there's something recently that kind of changed my perspective. So I want to share that with you in case it's of benefit to you as you're processing this information that's presented to you today. So I want to point out that this is not a zero-sum equation. So in other words, if we increase access for one patient population or subpopulation, that doesn't mean that we're taking it away from the other. So in other words, increasing access for OHP members doesn't take away access for privately insured patients with insurance that isn't organ-based. And simply stated, I think we're not creating disparities with this policy. We're simply helping to mitigate disparities that already existed and that currently exist by increasing access within a patient population that, generally speaking, has less access to fewer resources as compared to others. For example, in thinking about it a little more, I'm not as worried about increasing access for someone with private insurance with a median household income of 200,000 plus, with adequate resources and appropriate agency, who can afford to choose where, when, how they procure their health care, or has the appropriate means to take care of their children while they seek that care, or has access to remote options when they can't. I'm more worried about the single parent who's taking care of the children, working 3 jobs just to make ends meet, who may not have the luxury of choice like many others do, whose only option for this type of care could very well be the community pharmacist standing on the other side of that counter that may be able to use the standing order that we're going to talk about today. Therefore, I think the healthcare community writ large has an obligation to do what it can, where it can, because any discernible improvement in the health, safety, and welfare of even a small segment of the population will ultimately affect and improve that of the whole. It's my personal opinion, take it for what it's worth, and we'll start to go down through those. So as mentioned here, one of the primary barriers was the requirement in rule under general prescription requirements for a prescription to have or to represent a valid patient practitioner relationship, which you'll see there. I believe it's in 1D. So that's one of the elements that the rule revision targeted. So here we have in number 7, the language added. If the patient is relying on a standing order prescription issued by the public health officer appointed under ORS 431.045, or a physician licensed under ORS Chapter 677, who is employed by the Oregon Health Authority to obtain an over-the-counter oral hormonal contraceptive, the drug outlet does not need to ensure that A, there is a patient practitioner relationship as required in subsection 1ED of this rule, and The prescription contains the name and date of birth of the patient for whom the drug is prescribed. Okay, and as with a lot of our rules, this subject will be present in more than one division or location. So here we have it, I believe it's 11:30.
I went too fast, yeah.
Yeah,
Eight
it's in the
115
pharmacist
0130, sorry.
So same amendments. Initially, it was presented or present in the operation of pharmacies, Division 41, and here it is again in the 115 Division pharmacist. Okay, next I'll read the letter of support. Says, Dear Oregon Board of Pharmacy, the Oregon Health Authority, or OHA, strongly supports the proposed rule amendment allowing pharmacists to dispense non-prescription oral hormonal contraception to Oregon Health Plan members pursuant to an OHA-issued standing order. Unintended pregnancies are associated with adverse maternal and perinatal outcomes, including delayed or insufficient prenatal care and an increased risk of preterm birth. Non-prescription or OTC hormonal contraceptives, judged safe and effective by the FDA and national clinical societies like the American College of Obstetricians and Gynecologists, offer a promising strategy to reduce unintended pregnancies. However, cost remains a substantial barrier to access for low-income people. Under federal Medicaid law, no medication, whether prescription or OTC, may be covered by Medicaid unless prescribed by a licensed practitioner enrolled in the state's Medicaid program. To address this, OHA has proposed a standing order for non-prescription oral norgestrel for contraception and oral levonorgestrel for emergency contraception, signed by a licensed OHA physician enrolled as a state Medicaid provider. This approach would meet federal requirements and allow Medicaid enrollees to obtain these OTC medications at no cost, while pharmacists would retain their responsibility to exercise appropriate professional judgment in dispensing OTC medications. The standing order would help expand equitable access to safe, effective contraception across Oregon. Thank you for your consideration for this letter of support and the corresponding rule amendment, and that's signed Dr. Sejal Hathi, Director of OHA. President Joyce, I'll turn it back to you for board discussion.
Board Member Patel, comments?
So we are going to have we are going to add 7 that we are going to have the standing order. You don't have to verify the licensee, don't have to verify patient practitioner relationship. And the prescription contain the name and date of birth of the patient to whom the drug is prescribed. So that's what we are going to do. So, okay, so this one is good for the Maddie. So we are going to have NPI, pharmacist or the provider of the Oregon Health Authority. Oregon Health Authority provider NPI. So I don't see any problem then. I think it's good. Thanks, no comment.
Board Member Kroger?
Board Member Kroger, thank you for the work on this. I think this looks great. I think the only question I would have is on the new language, the part to obtain an over-the-counter oral hormonal contraceptive. That could be limiting if there is future discussions on other types of products that OHA might determine they may want to have under a standing order. So right now it is limited to over-the-counter oral hormonal contraceptives, but we don't know what the future holds. So I wonder if it would be wise to strike that part of the language, so that it's more adaptable for future use.
Executive Director Runyon. I entertained that same idea. Once again, Board Member Kroger, I think sometimes we think too much alike. And so I explored that, and through those explorations, with a couple of representatives of OHA, they determined that as it stood, last we spoke about it, that they were not aware of any further intent to add any additional over-the-counter medications, be they anti-inflammatories or antispasmodics or and other medications. So I understand that, and we did explore that, but as of the last time we spoke about it, they declined to pursue that because there was no further intent. And then, if there was at some point, I think the process would be a much more truncated process compared to what precipitated this or out of this. We would already have this in rule, so we could come back with enough advance notice and make some simple rule amendments there. But I appreciate the insight there.
Yeah, Board Member Kroger, thank you. I get that right now there's, contemplation for that. I still think that the intent and the limitations within this language would still be there. We don't know what the future holds, 5, 10, 15 years, public health emergency, that this potentially could be used and much more quickly without having to go through even a truncated rulemaking process. So that I kind of stand by the suggestion to obtain that kind of a qualifier on obtaining that type of medication. If it's limited by, a public health officer appointed, all of those other limitations, if OHA doesn't want to do those things, they don't have to. But if they do decide to, then there's more steps and it slows down that overall process. So that just might be my personal opinion, but I kind of stand by the removal of the qualifiers within that statement to make it more flexible. If in the future may never happen, but if it does, it would be quicker.
Okay, Board Member Pinello.
Member Pinetto, thank you for all of your hard work on all of this. It's something that has needed to come forward. And I appreciate all your work and everyone else's involved.
Member Chen.
Board Member Chin has no comment on this. Thank you.
Member Hall.
See it moving forward.
Seth.
Glad to see it moving forward.
Member Hall.
Board Member Hall, yeah, I'm fine with it. I was thinking the same thing, limiting oral, hormonal contraceptives. We wouldn't want to have to go back later. We could just pick that, but what everybody else thinks, but otherwise it looks good.
As Board President Joyce, yeah, it's about expanding healthcare access and public safety, so I definitely support this. And also, excellent point on, there's only 2 over-the-counter OTC, or there's only 2 OTC meds mentioned in this text, which is very limiting, and some kind of modification of the language maybe to be more expansive, but your comment on an addendum or, just getting something in place now and potentially having it change later, whatever needs to be done. But, that's it for me. Board Member Kirkbride.
Got a big smile, but Victoria wasn't looking. I had the exact same thought. I agree. It is much more beneficial if it's more broad. And even recently, if we had a rule where the public had access to a standing order prescription for something that could have been beneficial. as long as it doesn't change the intent, I would recommend we go ahead and strike that language and keep this broad. I also think it accomplishes the mission of, we've talked about looking at our rules and not having all these like onesie twosie things like plugged in. And if you're looking at this section, which talks about requirements of a prescription, it does fit in much more nicely if it's more of a broad statement versus just this, oh, and then there's this over-the-counter contraceptive statement kind of out of nowhere. And so I think it just fits nicer without mentioning the over-the-counter hormonal contraceptive. And then can be applied for any situation that might warrant in the future.
Member Smith.
Member Smith, no comments at this time.
Anything else to add? Back to you, Gary.
It's back to for a motion.
Motion?
Yeah. All right,
Okay.
Staff Member Melvin, back to you, President Joyce,
All
for
right.
board consideration for a motion, unless
Tennis.
board members have questions.
Any additional clarifications or questions? Otherwise, we will move this forward. However, go ahead.
Yeah, was there.
Wait, Angie, what is she saying? Sorry.
Well, I mean, what can we do, as Board President Joyce, at this time? But can we ask for a modification of the language and?
You've not voted on anything on the yet, so you're.
Board Member Patel, if we can, we would love to, but my eye is in the. So I didn't say anything, but yeah, if we have a choice, we can. I think that would be ideal.
So Board President Joyce, so that the consensus seems to be, that we want to maybe address the language as discussed. Board Member Kroger.
Member Kroger, so my thoughts on this would be, the board seems general consensus to remove the qualifier of the over-the-counter oral hormonal contraceptive. Then the next step would be, we would move this to a public comment period, or would we be soliciting more feedback?
You guys haven't voted on this at all yet, so what the whole plan of today, right, is just to vote to initiate rulemaking.
Oh.
And then once you vote to initiate the rulemaking, then it goes to public comment. So it's a good time to change it now if you want to. And I think those significant change, something along the lines of a drug, right, like we just want to change
Or
that.
device, yeah.
Your advice.
So, because my thoughts is then, Gary, you'd be able to, we would be able to get feedback from OHA and others on if they're supportive of this generalization change. We could do that through that process. So if we hear today, this is what we like, let's figure out if others also like it, and then we can go through that process. And it can always come back to this through that process. At some point.
So once you vote to initiate rulemaking, right, then it goes to the public for comment. They do written comment and there's the hearing, and then once that is all complete, it comes back to you to vote to adopt the final rule. There's lots of other steps that happen in between that. But if it came back and you wanted to change it back, you potentially might have to start over again. So potentially, I don't know, I have to look at that and do analysis there too.
As Board President Joyce, so Board Council, is public allowed to make a clarification?
They can speak on it now, yeah, you guys have not initiated anything on them.
Yeah, I mean, the public in the room.
I'm sorry, the OHA guest? Our guest from OHA, is that what you're
Yes.
asking?
Yes, is she allowed to provide comment at this time?
Yes.
Okay. So Dr. Dawn Mottner, please take a seat and,
Good afternoon. Thank you for welcoming me. My name is Dr. Dawn Moutner. She, her, and they are my pronouns. I serve as the Medicaid Medical Director for the Oregon Health Authority. Appreciate the opportunity to speak to the board, staff, board members. The suggestion of board members to strike the specificity that limits this change to over-the-counter oral hormonal contraceptives is welcome by Oregon Health Authority staff. In acknowledgement of the observations you've made about not knowing what is coming and the potential utility of the opportunity for standing orders in the future, still held safely within the guidance of licensure requirements, coverage requirements, et cetera, is a welcome change that you have suggested.
Thank you.
Thank you.
Thank you for your, information. Do we have any questions for Dr. Montner or any need for clarification on anything? I mean, going forward, go ahead, Barbara.
Sorry, this is board member Jim. So, it would read to obtain
A drug. or
a drug
device.
or device. Okay.
Entire thing.
I think we're taking it over the counter.
This is all within the
Replacing
intent.
the contraceptive drug with the-
And this is board member Chin, and then OHA has the standing order list for licensees. Awesome. Thanks.
All right,
You need to strike over the counter.
Oh,
It would be obtain a drug or device.
okay. Can you read it for the public that are just listening on the phone? You need to read that. They may not be able to see this.
Oh, right, it would have to be struck. That's not.
Go ahead. So now read.
Executive Director Running. So just for those on the call who can't see the screen, I'll read the revised language per board direction. So if the patient is relying on a standing order prescription issued by the public health officer appointed under ORS 431.045 or a physician licensed under ORS Chapter 677 who's employed by the Oregon Health Authority to obtain a drug or device, the drug outlet does not need to ensure that it goes down the list of criteria from there.
Okay, and we're gonna do the same thing in Division 115.
Yeah.
any suggestions?
It needs to be a comma.
Well, it's at the end. I didn't strike the comma, so it is at the end. Let me fix 115 really quick too. To obtain a, right? See that comma right there? I'm not gonna strike that. Good.
It's two.
Mm-hmm. And A right one?
To obtain.
Okay. I would make a statement that we also monitor the own phone. Whatever.
Board member Kroger, one flaw, of my own thinking. Do we want to add a qualifier with, so the part or a physician license under ORS Chapter 677 is broad? That's, so, but we're trying to limit this to, because it's not an and, appointed public health officer and physician license. We're not saying standing orders by physician license, any physician license under ORS Chapter 677 is allowed to create a standing order for any drug or device. So we're not opening that up, correct?
Who is employed by the ordinance?
Gotcha. Okay, just keep reading. Thank you.
Yeah.
Sorry, I just had a moment of panic. We just changed our own standing order.
Yeah.
Dr. Montner, go ahead.
Thank you, Don Mounter. It may be that adding a comma after Oregon Health Authority will contain that phrase such that you are
Yeah.
specifying that it's only physicians who are either the public health officer appointed under said ORS or a physician licensed and employed by.
Better? Good? Okay, President Joyce, for this motion, you would want to say revised in this case. Thank you.
Is there any more comments, clarification? Any more questions for Dr. Mautner? No? Okay. Is there a motion to move to send OAR 855-041-1105 and OAR 855-115-0130 as revised to the November 2025 rulemaking hearing?
So moved, Board Member Kroger.
Again, Board Member Kirkbride.
Board Member, I'm sorry, President Joyce, yes, Board Vice President Kirkbride.
Yes.
Board Member Chin,
Yes.
Board Member Hall.
Yes.
Board Member Kroger.
Yes.
Board Member Patel,
Yes.
Board Member Daniel,
Yes.
Board Member Smith.
Yes.
Motion unanimously passes. We will now review and discuss a new proposed rule related to criminal conviction determination process with legal counsel Hunt.
Thank you.
Dr. Bachman.
Thank you.
Okay, give me just a second. Okay, mailing C1, ready to go.
This is the rule, that is in response to Senate Bill 1552 that, provides basically a process for people to seek predetermination, based on a criminal conviction, prior to starting school.
Council Hunt, can you pull your microphone a little closer? Thank you.
Want me to say that again?
No. Did you have anything else in the gray box you want to discuss? You won't just go down to the rule. Okay. And this is a brand new rule that we're proposing. Did you want us to go ahead and read this for you? Because we usually present it and we read it. For people on the phone that can't see our screen, we usually read brand new rules that are proposed. Okay.
Sharing the screen, so.
Yeah, I'm sharing the screen, but people that call in on audio cannot visually see this, so we usually read newly proposed rules.
Okay,
Thank
so-
you.
Prior to beginning, required education or training, really just say my accent. Convicted of a crime, may petition the board for, for determination as to whether a criminal conviction will prevent the person from receiving a license issued by the board. To be complete, a petition must include the following: a complete and signed determination request form, the required fee of $100, the following records related to the final judgment of each criminal conviction, a certified copy of the judgment of criminal conviction, any charging documents, the arrest reports, probation and parole records if they exist, a written statement from the petitioner regarding the facts underlying the criminal conviction and intervening circumstances, a written statement or other document listing all criminal convictions, including dates of conviction and summary of the facts if the petitioner has more than one. If any of the records in 2C no longer exist, have been sealed or otherwise unavailable to the petitioner must provide evidence from the agency that held the record that the record no longer exists. A petition is incomplete when it is missing one or more of the items required in this rule. An incomplete petition will expire 60 days from the date the petition form was submitted to the board. Petitioners who allow their petition to expire must file a new complete petition, including the required fee. The petition and the board's determination are subject to Oregon Public Records Law, and unless an exemption applies, the information in the petition and determination are subject to public disclosure. The board will reconsider a determination that a criminal conviction prevents the person from obtaining a license when the person submits a completed application for a license. Upon consideration, that's why we should have shorter rules. Upon consideration, the board may rescind a previous determination that a criminal conviction does not prevent the person from obtaining a license if the applicant has allegations or charges pending in criminal court, has failed to disclose a previous criminal conviction, has been convicted of another crime during the period between the determination and the person's submission of a completed application for an occupational or professional license, or has been convicted of a crime that during the period between the determination and the person's submission of completed application for an occupational or professional license became subject to a change in state or federal law that prohibits the licensure from an occupational and professional license because of a conviction of that crime. Failure to disclose a previous criminal conviction includes any misrepresentation or a prior criminal conviction, any concealment or failure to disclose a material fact about a prior criminal conviction, or any other misinformation regarding a prior criminal conviction. Nothing in this rule prohibits the board from denying licensure when the person submits a completed application for a reason other than the conviction of a crime. A determination under this rule is not considered a final determination of the board.
All right. Let's go around. Board Member Kroger, concerns, issues, clarifications.
Board Member Kroger, I don't have strong opinions on this. I'm assuming all those words are needed, unfortunately. Okay, if it's really kind of what's minimally needed per the statute, then I feel comfortable moving forward. Thank you.
Board Member Pineda.
Board Member Pineda, nothing to add.
Board Member Chin.
Board Member Chin, nothing to add.
Member Hall.
Board Member Hall, no additional comment.
Board President Joyce, can you just give us like a real life example when this would be used? Just, I mean, it seems clear, but just a real life.
I think it's probably, I think we'll probably get it used when people don't necessarily even need to use it, so that'll be interesting. I think, essentially you did something when you were young and now you want to go to pharmacy school, so you need to make sure that that's not gonna prohibit you from going to pharmacy.
Board Member Kirkbride.
Yeah, I have no questions about the language. I feel like, we probably don't have a lot of wiggle room there, but I do have concerns about this potentially being used for minor incidents and students being, overly concerned, perhaps not knowing much about the licensure process at the very start of their academic careers. So we'll see.
Smith.
Board Member Smith, no further comments at this time.
Patel.
Patel, no comments at this time, so this is proposed. Then we'll go to the public comments, okay. But no comments at this time.
Okay, so, let me go ahead and send it. Is there a motion to move to send OAR 855-104-0155 as proposed to the November 2025 rulemaking hearing?
I'll move Board Member Smith.
Is there a second?
Again, Board Member Chin.
Board President Joyce, yes. Board Vice President Kirkbride.
Yes.
Board Member Chin.
Yes.
Board Member Hall.
Yes.
Board Member Kroger.
Yes.
Board Patel.
Yes.
Board Pineda.
Yes.
Board Member Smith.
Yes.
Motion unanimously passes. Okay. So we will now review and discuss Division 143 Pharmacy Prescription Locker Rules, mailing C2, C2A with staff member Efremov.
Yes, come back. It's gonna be, I'm gonna try to navigate your comment. I just want to be able to see. I just can't see Rich. And then just tell me if you're ready to speak. This isn't an edited version.
So we're doing a PowerPoint.
Oh, no. I have this ready. Never mind. Okay, give me a second. I have eight. Bro, hold on just a second. Ugh. Okay, now we're.
All right, this is staff member Ephraimov. Good day. We are about to transition into discussing pharmacy prescription lockers. Next slide. So as always, we start off every policy discussion with our mission to help us guide through our conversations. The mission of the Oregon Board of Pharmacy is to promote and protect public health, safety, and welfare by ensuring high standards in the practice of pharmacy and through effective regulation of the manufacture and distribution of drugs. Next slide, sorry. So why are we discussing this today? So as the board can see, the rules prioritization list adopted at the April 2025 board meeting placed pharmacy prescription lockers, or commonly referred to as PPLs, in the immediate and high categories. Since it is located in the immediate category, staff has brought this forth to the board and will continue to bring forth other 2025 legislative mandates before moving to the other high priority category rules items. Before moving on, I wanted to also talk, before moving to the other high priority rules, we will be doing the legislative mandates. As you can see there, in the immediate category is the legislative mandates. So for what had passed in 2025, Senate Bill 236, pharmacy prescription locker means a mechanical device that serves as an extension of a retail drug outlet's will call or point of sale area in which completed patient-specific prescription drugs, devices, and related supplies and non-prescription drug devices and related supplies are stored for pickup. A retail drug outlet may operate one or more pharmacy prescription lockers located within the state. A retail drug outlet may operate one or more pharmacy prescription lockers located within the state that need not be at the same physical address as the drug outlet. A pharmacy prescription locker operated pursuant to this section is considered part of the retail drug outlet, and a separate license or registration from the state board is not required. Because of this, the board must update the rules to be in alignment with this new law. Staff has already removed the PPL registration applications from the website and have updated the retail pharmacy registration applications to include requesting information regarding this location of PPLs. And we also are looking into adding this to our pharmacy renewals. In a later slide, at the end of the presentation, we will also address the board's strategic plan direction for the division vision. The division vision revision began in 2022 and aimed to methodically and thoughtfully update all divisions. It's recommended that PPLs be included as part of this revision of Division 41, seeing that a PPL is now part of a pharmacy and thus part of Division 41. Division 41 is included here in the high priority categories, but looks like we're on the next slide.
Oh, sorry.
Next slide. Context is always critical in conversations, and it's helpful to know where you've been before you decide where to go. And that's why we wanted to provide a brief history of PPL rules before this conversation. Rules were currently adopted during the April 2022 board meeting to be effective upon filing in April 2022. Your resource folder also includes information reviewed as part of previous board discussions to create these rules that were part of those public mailings. They included a tech forum and other state rules at the time. The plan for today's festivities is to begin by providing standard rule parameters for board to consider as part of the PPL policy discussion. In this section, I'll highlight common parameters from NABP model rules in other states for the board to consider when you begin your rule review and policy discussion. No decision or direction is planned to be made during this presentation. This is just to help frame the context of the policy discussion that will occur after this. When the presentation is complete, we'll pull up the proposed PPL rules and begin rule review and policy discussion. Staff will highlight required changes per law and highlight areas for policy discussion. So the goals for today, the goal is this presentation to provide background information to provide and frame context to the conversation in order to give a clear understanding of what's being asked in this policy discussion and how that fits into the bigger picture of the board's work. And to have the policy discussion today to get forward feedback on necessary changes required by law, but also the bigger picture direction of the rules overall is needed for this specific section. We will go through the rules set by set to get board feedback, and then staff will take board direction, apply that direction to the rules, and bring back at a future meeting. There is no scheduled timeframe when these rules need to be adopted. Sooner than later would be great to be in alignment with the new laws, but we want to make sure the board has the time it needs to discuss these, to get public input and make thoughtful changes. We are not asking the board to send these to rulemaking or hearing at this time. We'll continue to communicate and summarize at the end of each discussion to ensure that the board's direction and next steps are clear to the board and the public. Okay, to dive in. The thought process here of what to consider is really to begin defining attributes or parameters that a locker must meet to operate safely, and to ensure that a prescription is accurately filled, integrity is maintained, and the prescription is delivered to the correct patient. One might say this is our stretching exercise before we start to run the marathon, with the rule policy discussion being our metaphorical marathon. In assessing NABP model rules and other state regulations on automated dispensing machines, or direct-to-patient dispensing, or as we know them, lockers, there were 4 reoccurring parameters identified: safety and security, patient interaction and communication, technology, and record keeping. As part of this discussion, it's important to keep in mind that whatever requirements are determined, they should be conveyed to licensees in a manner where they will know what is expected of them. For example, someone could see the term pharmacy prescription locker and think a high school locker could be utilized to leave prescriptions in for pickup. If safety and security parameters are needed to ensure the integrity, accuracy, and safety of patients' prescriptions, those will need to be accounted for or outlined in the rules to specify what conditions a locker must meet to store and deliver drugs. Next slide. It's important to note that when reviewing and assessing other state regulations, many speak to the fact that all pharmacy dispensing requirements are already in place as a baseline. Pharmacist DUR, verification, correctly labeling, etc., prior to the prescription being placed into the locker. And some states indicate that a specific state licensee or a specific state licensed pharmacist must perform all clinical services as part of the dispensing process, included but not limited to DUR and consultation. Now, looking at specific common parameters for safety and security that were identified by the NABP model rules and other state rules that have automated dispensing, direct-to-patient dispensing, or locker-like regulations, it's important to note that many of these were already accounted for in the board's current rules as they are. First is locker location. This means the physical location, for example, where the locker must be kept, like an enclosed building. Some other states had regulations related to geographical limitations or distances. Pharmacist supervision. RPH should provide a method of communication and be accessible at all times when automated system is operational. Many states also account for video and auditorial communication, as making sure that there's a system to allow for an appropriate exchange of oral and written communication for patient counseling. And if the system is not functioning, making sure that those processes cease until it is. Storage, to maintain quality, potency, and purity of all drugs by storing at manufacturer recommendation conditions in transit and while in the machine. Preventing theft and diversion, ensuring appropriate security measures and monitoring of inventory to prevent theft and diversion. Preventing unauthorized access, securing the machine, monitoring access to only ensure permitted persons access. Maintaining confidentiality, ensuring they comply with federal and state laws to ensure that patient information is kept secure and confidential. And some states even go further by specifying the requirement of 2 identifiers like name, date of birth, or unique code to ensure it's dispensed to the correct patient. PIC, or as NABP called, designated pharmacist with specific duties. These include assign, discontinue, or change access to the system as needed, stocking and destocking, may only be completed by a qualified person under the supervision of a licensed pharmacist. Most states further identify a qualified person as a trained licensee and only permit a licensee to perform these functions. Self-inspection required to be completed. Most states require it at the same time as their pharmacy inspection. Adequate staffing to provide this service, since this is an extension of the pharmacy for most. Training, ensuring that there is specific training to installation and then annually thereafter for operation of the machine. Permitting return of drugs from the machine to the pharmacy, as long as they are returned to the pharmacy in the same condition and maintained in the same condition as they would be if kept in the custody of the pharmacy. Ceasing operations if the machine is not functioning correctly or all other rules have not been met, that the system would cease to operate. Continued quality improvements. All error or complaints must be investigated as part of the pharmacy CQI plan and take appropriate action. And then finally, address typically in PNPs that the outlet must have PNPs on security of the drugs and devices of the system, determining inclusion criteria of which drugs are appropriate for the machine, meaning which can be safely delivered to a patient through this mechanism. For example, a drug product that requires further manipulation, say reconstitution, may not be an appropriate option. Communication with patients, making sure that patients are aware that consultation by a pharmacist is available for any prescription. What to do if the machine malfunctions, and ensuring patients receive prescriptions as expected if the machine is disabled or malfunctions. Licensee responsibilities, clearly describing assignments, responsibilities, and training of pharmacy personnel on the use of the machine, including maintenance and filling. Drug integrity, maintaining drugs, devices, and medical equipment at temperatures, humidities, and other environmental conditions to ensure that they do not become adulterated, and to ensure that they are transported and stored in accordance with the manufacturer's recommendations. Operations, including stocking and destocking, removal of outdated or recalled drugs. And maintenance, add overall maintenance to the machine to ensure that it functions correctly, and example, downtime procedures. There are some additional requirements that some states have, limiting the number of machines that can be operated by one pharmacy. North Carolina says only up to 3. California gives an example of no further than 60 miles. So just some others that were kind of outliers. Next slide. Patient interaction and communication. So most of the standards that were listed by other states and the NABP model rules talk about patients must consent to having their prescription placed in the locker. So having authorization and documentation of such. Orienting patients to the use of the machine, whatever is necessary to make sure they can safely and effectively use and access their prescriptions. They also have a series of required notifications, consultation, when consultation by a pharmacist can be available or made available. When a prescription is not available to the machine, that there is a function for the patient to be able to get access to their prescription, so making other arrangements. Pharmacy contact information if the patient needs assistance with the machine or has other questions, that there is the available communication for them to know how to get that help. Releasing to the correct patient or patient's agent. Some states have a system that requires them to identify each patient and ensure that correct delivery. And finally, video and auditorial communication. Systems to allow for that appropriate exchange of oral and written communication. And if that system isn't functioning, that the machine should not be operating and prescriptions should not be dispensed from such. Some regulations go a little bit further and require to have a real-time connection and a state-specific licensed pharmacist available during the time of operation. Next slide is technology. So some of the safety and security features do blend into technology section as they are needed for security, but most states do specifically call out certain technology related to minimum requirements to achieve those safety and security parameters. So most of them have a security system requiring tracking and identification. So under continuous pharmacist supervision, must prevent unauthorized access, must have complete and accurate records of all transactions that include all users accessing the system and all drugs added to or removed from the system. Example, requiring passwords, biometrics, or other codes to identify and track individuals. must protect patient health information, must have inventory management, appropriate security measures and monitoring of inventory to prevent theft and diversion, an ability to identify or notify pharmacy when not operating or functioning correctly so that they can make alternative arrangements for patients to pick up prescriptions. Patient identification. They must be able to identify each patient and release to the correct patient or patient's agent. Some states require a picture and stored images of the patients when receiving the prescription. And lastly, second to last, video and audio communication system, again, allowing for that appropriate exchange of oral and written communication by the pharmacist to the patient. And finally, video surveillance. Fewer states have this requirement for continuous recorded video surveillance of the system and any persons accessing the system, and have requirements for how long they must maintain that data. And the last tenant or parameter, sorry, next slide, is record keeping. So record of prescriptions, most require the name, strength, dosage form, and quantity of the drug added to the machine and accessed by the patient and who that patient was. To be maintained, documentation of the prescription was added to the machine, who it was dispensed to, and if not dispensed, if it was returned to the pharmacy, who was the person to return it, and documentation that the patient consented to those drugs being placed in the PPL. Most require a record of PPL access. So again, identification of the system accessed, identification of the individuals accessing it, and the types of transactions that have occurred. And really, most of them basically have a requirement of complete and accurate records of all transactions that include all users accessing the system and all drugs added, removed, or removed from the system. And finally, a surveillance system, again, that's alluding to the continuous recording. Some states are very specific and have requirements to store those for 60 or 90 days, depending on the state that you are at, but that was not the majority of states. Next slide. So as I mentioned at the beginning, on the rules prioritization slide, as a reminder, that we were alluding to the board strategic plan and the division vision. So you can see here is the board's division vision that was adopted in 2022 as part of the board's 2022-2026 strategic plan. You can see there's still a significant amount of work that needs to be done, but luckily most is accounted for in the rules prioritization plan that you saw earlier on slide 3. So for example, you can see universal rules, fees, CPE, RPH, CPT, PT, and intern regulations were all recently updated and adopted. The board took 2 solid jam-packed years to rework all of the people divisions with the rules effective 3/1/2024. So seeing that the people or licensee updates were complete, the board then directed staff to focus on more places, more commonly referred to outlet regulations. That brings us to where we are today. Looking at the middle column, you can see that Division 41 has been separated out into multiple divisions, most notably the retail drug outlet, or otherwise known as the RP, and institutional drug outlet, otherwise known as IP, are independent of one another. This was due to feedback the board had received from licensees that Division 41 was overwhelming, or is overwhelming, to understand, and that it's difficult to tease out what is an RP rule and what is an IP rule and when it applies to both. So with the vision, a new division of 136 would be specifically for an RP pharmacy. And within that 136, it would list general requirements and separate sections for additional pharmacy services provided. So for example, if someone was performing central fill, it would be all RP rules apply. And if you do central fill, these rules apply. So we envision something similar for PPL. For example, if you operate a PPL, then these additional requirements apply. For the sake of time and ease of review, for the board and the public, staff has provided suggested amendments on today's current 143 division as it is. Our goal, if the board deems appropriate, would be to transition this section in a phased approach. Due to competing priorities and limited resources, it's really not possible for us to move this directly into 136 right now. So what we would like to do is to transition these back into 41, which will then be incorporated when 41 moves into the larger 136. That was it. Sorry, yeah, so there's many other steps that we're trying our best to really have a transparent discussion in a way that's easy to understand as possible. I know many of you are aware rulemaking processes are not always easy and intuitive, and Secretary of State filing requirements are not easy to understand, but luckily we have HAG Hunt and staff member Melvin here to help us, but just trying to give the big picture view of what we're gonna do next so that we're all on the same page. And with that, next slide would be to transition into mailing C2 for the public, but want to pause if there's any other questions or discussion for the board on anything that's been communicated here before we actually dive into the policy discussion.
Don't see any hands raised.
Member Patel, for Member Patel, so right now we are going to do policy discussion, right?
Correct.
So usually like rulemaking, like first review, second review, third review, then go to the public hearing, come back to us, right? So this is just I would assume like this is the first review.
So staff member Evermont, I would even maybe call this like a before first review, because first review is usually we actually come to you with language. And so in talking with staff, and maybe taking a different approach here as we're trying to look at things a little more transparently for the public, but also to give the board more ability to give clear policy direction before we write rules. We thought it was a good opportunity because we do have to strike a lot of things from the law. So there are some non-negotiables unless you want to violate the law, which I don't think the board wants to do. But from that, though, there's been a lot of discussions on this section already. We're coming up at, 3.5, 4 years. It seemed like a good time just to start fresh and have a full deep dive. So this is first look from this. The goal would be to get consensus and then move on to draft rules, which then would come back to the board and be what maybe you're alluding to as first look.
Joyce, I think we're good to keep going. I know this is. Yeah, I started looking at this back in 2021. Anyways.
Staff member, just for clarification too, before we dive into this, I know there was a break scheduled for
2:30.
2:30.
Yeah.
You still want to dive in for 10 minutes? And wait?
Actually, I think let's take a break now, right? And then come back in 10 minutes and then we'll just start it.
Thank you.